Imagine a scenario in healthcare where every single second truly counts.
Yeah.
We're talking about moments where the swiftness of a medical intervention can quite literally determine a patient's long-term health, their well-being.
It's intense.
It really is. This is the reality for millions of people around the globe living with epilepsy. And when a seizure goes on for too long, it's not just a passing event, is it?
No, absolutely not. Prolonged seizures, status epilepticus, can unfortunately lead to severe neurological damage, persistent cognitive issues, and a whole host of other chronic health problems down the line.
Right. So the core challenge for clinicians is pretty clear. How do we rapidly stop that seizure activity, but crucially, while absolutely ensuring patient safety?
Exactly. That balance is key.
So today on the Deep Dive, we are plunging into a crucial review of exactly that. How quickly can we safely and, effectively administer intravenous anti-seizure medications, ASMs? We'll be shining a spotlight specifically on 3 drugs often used right on the front lines: lacosamide, levetiracetam, and valproate.
That's right. And our mission here, for you listening, is really to synthesize and make sense of the latest literature on this. We've explored a pretty comprehensive narrative review. It pulled together insights from 45 different articles.
45?
Yeah, everything from rigorous randomized controlled trials to detailed cohort studies. The main goal was to characterize the safety and efficiency of rapid ASM administration and, well, really dissect what it means for current pharmacy practice.
Okay.
We're looking for clear, actionable insights that you can actually take away.
Okay, actionable insights. Got it. So let's unpack this. To understand the speed aspect, we're going to be comparing the main ways these drugs are given, right?
Right.
So intravenous piggyback, IVPB, that's usually slower, infused over time.
Typically, yeah.
Versus intravenous push, IVP, which is much faster, like a direct injection.
Exactly. And we'll also touch on the sort of related question of using these meds diluted versus undiluted. That comes up too.
Okay. And the urgency here, it really can't be overstated, can it?
No, it's critical.
When someone's having an acute seizure, the ideal ASM needs to work fast. Short onset of action, getting to those therapeutic concentrations in the brain quickly.
Absolutely. Time is brain, as they say.
But as you just mentioned, it's not just the drug itself. It's profoundly about how it's delivered. Historically, many ASMs had much slower administration rates. Why was that?
Well, it was primarily due to well-founded safety concerns. Think about the potential for cardiac issues or maybe other adverse reactions if drugs are given too rapidly. There was a lot of caution.
Right, that makes sense. But what's fascinating, connecting this to the bigger picture, is that we seem to be seeing a pretty substantial shift in clinical practice now.
We really are. Clinicians are now actively investigating using IVP, these faster pushes, and also much faster IVPB rates, sometimes even pushing beyond the official FDA-approved guidelines.
Really? Beyond the guidelines?
Yeah. And there's also growing interest in administering these medications undiluted. So it definitely raises an important question. Why this change? Why are clinicians challenging these established norms? And what are the benefits beyond just, speed?
That's such a crucial point. It almost feels counterintuitive, doesn't it? Speeding things up when safety was the original concern. So what are the drivers, based on the sources, pushing this shift?
You hit on it. It's not just one thing. It seems to be about enhanced efficiency, especially in critical care settings where time is precious.
Okay, efficiency.
Also, the potential for very significant cost savings for health systems.
The money aspect. Always important.
And even practical things that have become more pressing lately, like sterile fluid shortages. If you don't need to dilute, that saves fluid.
Oh, right. Didn't think of that.
Yeah, so all these factors have kind of contributed to this growing interest in faster administration. It's a convergence of patient need, operational necessity, and, frankly, economic reality.
Okay, so we've laid out the critical need for speed, this paradigm shift. Now let's take that lens and apply it to the individual drugs, starting with lacosamide. What did the review uncover about safely speeding this one up?
Okay, lacosamide. The overall findings here suggest that rapid administration, whether comparing IVP versus IVPB or looking at diluted versus undiluted, didn't show notable differences in patient outcomes in most of the studies looked at.
Okay, so generally safe to go faster.
Generally, yes.
Yeah.
But it's not entirely black and white. There are some nuances we definitely need to consider.
Okay. Like what?
Here's the critical part. There may be a dose-dependent increase in the length of the PR interval. That's a measure on the EKG, reflecting heart function.
Okay, heart rhythm thing.
Exactly. Specifically, studies reported increases around 6.1 milliseconds for a 200 milligram dose, about 8.6 milliseconds for 300 milligrams, and up to 10.6 milliseconds for 400 milligram doses.
10 milliseconds? Is that a lot, clinically speaking?
Well, that's the question. The precise clinical significance of that 10 millisecond increase remains somewhat uncertain. It's a signal, something to be aware of, but whether it translates to bad outcomes routinely is less clear.
Okay, so overall safety looks good, but there's this specific flag about cardiac function. Does that mean certain patients might be at higher risk or need closer watching?
Absolutely. And what's really important to acknowledge is that post-marketing surveillance, so after the drug was approved, has reported rare but very serious cardiac outcomes. Things like asystole,
Heart stopping.
yeah, where the heart completely stops beating, cardiac arrest, and even death. Now, these were noted especially in patients who already had pre-existing proarrhythmic conditions.
Meaning heart conditions making rhythm problems more likely.
Exactly, or patients already on other medications known to affect heart rhythm. And one study in particular found a notably higher rate of cardiac events, things like new-onset first-degree AV block, in over 22% of patients.
Okay, that's a specific heart block.
Yes, a mild delay in the heart's electrical signals, but still notable, and even atrial fibrillation, which is a common irregular heartbeat. These changes seemed more pronounced, particularly in patients over 60, those with diabetes, or known heart disease.
Right, so definitely need extra vigilance in those groups.
For sure. Particular vigilance is warranted there. But shifting slightly from an efficiency standpoint,
Yeah.
switching from IVPB to IVP lacosamide did show considerable improvement in overall efficiency, especially in that crucial time window from when the pharmacist verifies the order to when the medication actually gets administered.
Okay, so a clear win for workflow there.
Definitely.
Wow, okay. That distinction between the general safety profile and that specific cardiac vigilance, especially in certain patient groups, that's a key takeaway for lacosamide. So if we shift gears now from lacosamide's cardiac nuances, what about levetiracetam? You mentioned efficiency gains earlier. Does the research back that up? You said this is where it gets compelling.
Yeah, you're right. The literature for levetiracetam is actually quite promising. When it comes to safety, adverse effects were mainly mild, and they didn't seem to differ meaningfully between rapid and slower administration, or even between diluted and undiluted forms.
So pretty mild side effects across the board.
Yeah, the common things reported were like infusion or injection site reactions, maybe some hypotension, low blood pressure, or bradycardia, slow heart rate. Some agitation or delirium was noted too, but the rates were generally low overall.
That sounds like a remarkably clean safety profile then. But you hinted the efficiency aspect was a major highlight. How significant are we talking here?
This is where it gets really interesting. IVP administration of levetiracetam significantly decreased the time to administration. That's a big deal in itself.
Sure is.
But even more strikingly, it led to substantial cost savings.
Ah, okay. Real dollars and cents.
Absolutely.
Yeah.
For example, one study found a mean savings of almost $16,000,
$16,000 mean savings.
largely due to a decrease in wasted doses. Maybe less preparation time, less materials. Imagine that impact on a hospital pharmacy budget.
No kidding.
And another study reported a pretty considerable cost difference, too. About $14 per IVPB dose versus just $2 per IVP dose.
$14 versus $2 per dose.
Per dose. And administering undiluted levetiracetam also improved efficiency without seemingly increasing adverse event rates. So it's this powerful combination of speed and financial benefit.
Wow, that $16,000 figure is just staggering. That must be a massive benefit for healthcare systems, way beyond just the immediate patient care aspect. But were there any catches, any limitations we need to know about with those positive findings?
That's an excellent question. Always good to ask. It is important to note that the way they collected data on adverse drug events, the ADEs, wasn't consistent across all the studies.
Okay, methodological differences.
Exactly. And that could potentially lead to some underreporting, especially maybe for less severe events that did get systematically captured. So while the overall picture looks very positive, there's always that need for continued vigilance in practice.
Got it. Good caveat. Okay, so that's levetiracetam. Sounds very promising. What about the third one, valproate? What did the deep dive reveal there?
For valproate, rapid administration, again, whether it was diluted or undiluted, generally appears to be safe based on this review. Adverse effects were predominantly mild and manageable.
Like what sort of things?
Things like localized infusion-related reactions, some dizziness, somnolence, drowsiness, and nausea. Crucially, they didn't observe significant changes in vital signs like respiratory rate, oxygen saturation, heart rate, or mean arterial pressure.
Okay, vitals remain stable. That's reassuring. And were there any serious adverse events, even if rare, like we heard about potentially with lacosamide?
Serious events were indeed rare with valproate too. They saw a few cases of hypotension, 5 patients in total, but only 2 actually needed intervention, and they apparently had other contributing factors going on.
Okay.
And 2 patients experienced psychiatric adverse effects, 1 hostility, 1 confusion with encephalopathy, which is a type of brain dysfunction. So rare, but noted.
Right. And efficiency. Did we see gains there too?
Well, only 1 study directly compared IVP to IVPB for valproate, but its findings were pretty compelling. IVP valproate cut the mean time from pharmacist verification to the first dose way down,
How far down?
from 134 minutes down to just 27 minutes.
Whoa, 134 down to 27. That's dramatic.
It really is a huge reduction. Now, that study did report a somewhat higher rate of infiltration with IVP. That's where the medication leaks out of the vein.
Right, into the tissue.
Yeah. But interestingly, not phlebitis, which is inflammation of the vein itself. So faster, but maybe a bit more risk of infiltration to watch for.
Okay, so we've broken down the data now for lacosamide, levetiracetam, and valproate. Let's try and bring it all together. What does this all mean for healthcare systems and maybe most importantly for patient care? This is where it becomes really relevant for you, our listener.
Yeah, this is the crux of it, isn't it? These findings, taken together, provide pretty strong support for adopting faster administration rates for all 3 of these drugs, lacosamide, levetiracetam, and valproate.
Faster rates are supported.
Yes. And this actually aligns well with current neurocritical care guidelines for treating status epilepticus. It represents a significant shift, really, from the more traditional FDA labeling, which often recommended slower rates based on older data, perhaps.
So it's a move towards optimizing outcomes in these really acute settings.
Exactly.
But, it can't be as simple as just telling everyone go faster, can it?
Yeah.
When we accelerate drug delivery, my first thought goes straight to safety checks, practicalities for the staff. Are there big hurdles or practical things systems need to consider?
Oh, absolutely. That's an excellent point. And you're right, it's never just simple. There are definitely several practical considerations that came up in the review. One of the biggest concerns with IVP administration is the potential for medication errors.
How so?
Well, because IVP meds are often stocked directly on nursing units and prepared by nurses right there, it can introduce vulnerabilities. Things like maybe unnecessary dilution or mislabeled syringes, or even using pre-filled saline flushes for dilution, which isn't always appropriate.
Right, lots of little steps where things could go wrong.
Precisely.
Yeah.
So to mitigate these risks, it's really critical to follow recommendations from organizations like the Institute for Safe Medication Practices, ISMP, specifically for IVP meds.
Okay.
And this also just highlights the absolute importance of interdisciplinary collaboration. Pharmacy and nursing departments have to work together to develop standardized policies and procedures.
Makes sense. What else?
Another crucial factor is nursing workload. Giving an IV push dose can be done by hand or using a pump. But either way, it takes time and attention. So any transition needs careful thought about nursing resources, and you absolutely need input from all the key stakeholders during planning.
You get the nurses involved from the start.
Absolutely. And then there's the regulatory side. The United States Pharmacopoeia, or USP, has Chapter 797, which clarifies that drawing up multiple vials for a single IVP dose can be done as an immediate-use compounded sterile preparation. That gives some regulatory clarity.
Okay.
And for hazardous medications, like valproate, USP Chapter 800 adds another layer of complexity for safe handling. But interestingly, it might allow for pharmacy-prepared IVP doses to be drawn up in advance under the right conditions, which could actually help conserve fluids, especially if there are shortages.
Ah, so even the hazardous drug rules might have a workaround that helps efficiency.
Potentially, yes, if planned carefully.
It sounds like a lot of moving parts to manage, a lot of potential pitfalls. But here's the good news, right? Health systems are actually navigating these complexities and seeing real benefits.
Yes, absolutely. There are encouraging examples. For instance, one system that transitioned to IVP lacosamide managed to cut the number of steps involved in half.
Half the steps.
Yeah, and it involved 3 fewer personnel, which just underscores the power of getting all the stakeholders involved early and planning carefully. It can be a huge operational win.
That's fantastic. Fewer steps, fewer people involved. Sounds much more streamlined.
Definitely. But despite these successes and the generally promising data, it is important we acknowledge the overall limitations of the current research base.
Okay, what are the main limitations?
Well, most studies were retrospective, looking back at data, which isn't as strong as prospective trials. And there was significant variation in how they administered the drugs. different dilutions, different rates.
Making comparisons tricky.
Exactly. It makes it challenging to directly compare and synthesize results across all the studies cleanly. Also, as we mentioned with levetiracetam, the adverse event reporting was often inconsistent. That could easily lead to underreporting, especially of less serious ADEs.
Right.
It's also just hard sometimes to isolate the direct clinical outcomes, like seizure stopping from the patient's other underlying conditions or other medications they're on.
Yeah, confounding factors.
Right. And finally, specific efficacy data, like how well these rapid methods actually stop seizures compared to slower methods, is still somewhat limited for some of these specific techniques. We have more safety and efficiency data than direct comparative efficacy data right now.
That makes perfect sense. More robust, standardized research, especially in efficacy, would certainly strengthen these findings further. But even with those limitations, this deep dive has really shown us that ensuring safe and efficient administration of these intravenous ASMs is just absolutely critical for optimal patient care.
It really is.
Every second truly counts. And getting that medication in faster, but still safely, it just means better outcomes for patients facing seizures.
Absolutely. So, to kind of summarize the key takeaways for you listening, rapid IVPB administration of lacosamide, levetiracetam, and valproate appears generally safe.
With that caveat for lacosamide and cardiac monitoring in vulnerable patients.
Exactly, that's crucial.
Yeah.
And perhaps most notably, IVP administration, especially for lacosamide and levetiracetam, seems to considerably enhance efficiency and can lead to really notable cost savings for healthcare systems.
It's a compelling case, definitely.
It really is a compelling case for reevaluating some potentially long-held practices.
Yeah. And as healthcare continues to seek ways to optimize patient outcomes, use resources more wisely, these insights into rapid ASM administration are invaluable. It really makes you wonder, doesn't it? What other established medical practices, things that seem set in stone, might actually be ripe for reevaluation, where maybe seemingly small changes in how we deliver care could lead to such significant impacts, both for patient care and for operational efficiency?
That's a great thought.
Yeah.
Always worth questioning the status quo.
Definitely something to mull over until our next deep dive.